lockdown had started, a lot of media reports plus TV channel discussions were there that what would be the problems that people would face. A lot of migrant labor and people who are used to going to offices would be locked down, and working from home, and academic schedules of youth, and girls and boys who would have to sit at home, class 12 students, class 10 students, the uncertainty about their exams and the uncertainty about their academic schedule, so much so that even the Public Service Commission had to postpone some of their interviews. So it affects an entire generation, and it affects the faculty, the students, the entire fraternity of the academic field. But having said so, I think mental health is primarily the subject of the health ministry, in which there are mental health authorities at the central government level, and also mental health authorities at the state level that are headed by the chief secretaries and the secretaries of health, and the secretary health union is also heading the mental health authority at the center, and very many issues about identifying the problems, the prognosis, the diagnosis, and the treatment protocols have been laid out. And I think in our country, mental health being a state government, a state subject, the state government runs certain institutions. Every state government has a mental health institution or a mental hospital, as they are called. And the treatment protocol would be anything from confinement to giving them medicines, and it's both the psychiatric model and the medical model. But I think as a lot of institutions, despite the fact that some of the patients were treated and discharged, particularly the aged, women and men, they were not taken back by the society, and the stigma and the uncertainty that they would be able to cope with community living, or they would be able to come back and stay with family peacefully, was a matter of concern for everybody. That the court intervened and said that rehabilitation for such people who are discharged after having been successfully treated, we need to look at half stay homes and long stay homes. So while this is a matter of discussion between the state government, the health ministry, and we have also been involved in the discussion process, where we're looking at how many state governments are setting up these halfway homes, what is the protocol, and what are the kind of components that needed to be incorporated at the design stage, at the conceptual stage, so that the stay in terms of a dignified existence for a person who's been treated of mental health illness is such that he would be able to live life fully in terms of her or his livelihood and her dignity, her or his dignity. But I think the problem doesn't get resolved only by the halfway homes and the long stay homes, or by the mental health institutions that are in the state government, and even the National Institute of Mental Health and Neurosciences that's there in Bangalore, which is a center of excellence and a national institute which looks at both the neurosciences, it looks at mental health, it looks at counseling, it looks at medical and prescription of drugs. It also looks at how to rehabilitate the person in terms of its complete sort of holistic treatment that needs to be meted out to the patients. But I think as we are moving ahead with the mental health establishment of the Mental Health Institute, I would like to thank the Madhya Pradesh state government, and particularly our honorable minister, who was very proactively he was able to sort of get the land allotted. Initially, this institute was supposed to be built in a 2.5-acre plot of land. Now that we have a 25-acre land, it's going to be a sprawling institute. So I have had several sittings with the institute's executing construction agency, the CPWD, and the architect, to design and conceptualize what would be the architectural requirements. I think if I look back, I feel that we have been able to somehow anticipate and some of the problems that are going to be faced for counseling for all classes and categories of people, community counseling that would be required. What would the preventive steps to prevent people from committing suicide? And suicide should be decriminalized, and suicide can be prevented. And also, hereditary and episodic and bipolar disease and schizophrenia, which would need medicine and psychiatric treatment, would also need counseling. And a lot of women, youth, men, and labor, and particularly in rural areas where people are not able to express and acknowledge the fact that they're going through a mental health problem, which can be resolved by counseling, by talking, by accepting the fact that you have a problem in hand, which may, if left, neglected, can lead to chronic mental illness, is something which we need to address as academic and as medical and rehabilitation professionals. So this is my sort of message to all of you, that the protocols need not be that the counselor has to, summon the patient to his clinic or her clinic, and a counseling can be done only on the basis of a patient-doctor relationship. It can also be that I'm very thankful to all of you that all of you as a fraternity has come together and has set up all the helplines where people are asking questions and you are able to give time for counseling, and free of cost, that you have been able to manage, those people who would have otherwise had to access a hospital or a psychiatrist or a clinical psychologist, are able to sort of access these helplines. And our institutes have come in very instrumental in setting up these helplines. And the entire fraternity of rehabilitation and clinical psychologists need to be thanked, including the psychiatrists and the doctors who have come together in this times of crises where people would need such help. But as we go on to the post-pandemic stage, I think India should take a lead in mental health programs and mental health policies. And the vision and objective should be such where the community resilience and the family must be taken as a unit of counseling, and the protocols of mental health problems that are temporary in nature and seeking help should not stigmatize the family or the person. These are things which need to be sort of inbuilt into our systems and inbuilt into our sort of policies and programs, and such objectives will help people access mental health counseling and also go to a center which is which will facilitate proper clinical treatment. But having said that, I would say that certain patients, certain persons would also continue to need medicines. So that aspect where the medical protocol ends and the rehabilitation protocol begins is something which we need to understand, that they must go hand in hand. They need not work in silos and in an isolated and disjunct manner. We need to see that rehabilitation can help those which are temporary in nature, which are situational, environmental, which are certain twists and turns in life, whether it's a breakdown of relationship, whether it is something where an aspirational goal has not been achieved, and where there's certain failures which are temporary in nature, where one needs to understand that failures are the pillars of success. These are the things that we need to sort of accept and make them more democratized in their way of understanding, and making academic curriculum where community rehabilitation and community mental health programs take priority rather than clinical and counseling. Because all 130 crores of people can't be counseled. 130 crores of people, however, through a dissemination of behavioral science, through a dissemination of knowledge of change of behavior, change of attitude, empathy, and bonding and understanding and being with the person, helps the person in distress to overcome his distressful situation and prevents him from leading his stage of illness to a chronic stage of illness. So I think these are the things which we need to address, and I'm hopeful that we will engage some of the most experienced psychiatrists and clinical psychologists and academicians. Be that as it may, they are from AIMS, they are from RML Hospital, they are from NIMHR, and they are from private practitioners also, like Dr. Achal Bhagat and Sanjay Chugh, who used to write a column. I'm trying to engage them in the entire process of building a roadmap for the institutes, and the involvement of Melbourne Institute of Disability and Dr. Greg Norman, who's done a lot of work internationally on prevention of suicide. I think we need to see that the best practices and the scientific way of research and building protocols and building policies that need to be brought out from institutes like the National Institute of Mental Health and Research, that needs to be ingrained in our entire process of building the roadmap for the institute. So I'm very happy that all of you are getting together, even in these times of pandemic and COVID lockdown, and discussing and engaging everybody in this discussion. But at the end of the discussion, the policies and the objectives of all these seminars and workshops must come out, and they must not just remain in the institutes for academic purposes and for getting jobs, for teaching. It must come out as a science that can be disseminated, as a science which can be simplified, and where community knowledge and community behavioral science that is going to be engaging the world today is what we need. I think every human being will need some support psychologically, and this is what we are going to address. And I want that as a national institute, you must be able to raise the bar and earn the reputation of being an international institute where community and family and the entire support that we need to give to the country comes out from this institute, and it sets an example of how an institute can build policies and help the government make the entire treatment and the mental health problems that is going to consume all of us in a simplified way, treat the people and help them come out so that they can progress and grow in life. So thank you very much. I'll leave you all at that for discussion, and I would want that your presentations must be shared with all our institutes, and if there is any suggestion, observation that some of you make, those must be incorporated, and we should humbly put it on the table to say that this is what we should do. Whether we should use technology, whether we should also work in collaboration with health institutes, whether we should work in concert with community health programs or community education programs or community rehabilitation programs, where the convergence of improving public health and taking rehabilitation treatment to the doorsteps of the people is what we should address. So thank you very much. I will wait here to have a look at the presentation, and I will try to be here as long as you want me to be here. But since I have also got to attend to some other work, I would definitely like to see what were the discussions, and at the end of the day, what suggestions and recommendations came out from these webinars. So thank you very much. And please go ahead.